So, well, actually, I might
look at it with a different hat than a dentist. You're kind of missing a lot of the problems you see in front of you, like children who grind their teeth, children who have mouth breathers, gingivitis, kids who have a narrow palate, kids who have hypocalcification due to dehydration of their enamel. All of this is signs and symptoms of what we call sleep disordered breathing problems. Right? In the literature, there's a lot of stuff on obstructive sleep apnea. And if I just define the two, obstructive sleep apnea is where you stop breathing or you have a reduction of your airway, resulting in either an apneic event or a hypopneic event. But you could not have any apneic events and still increase the effort you need to breathe, which is called a RERA. And if you have a number of respiratory effects during your sleep, that's still going to disrupt your sleep. And the side effect of sleep disruption in children is totally different to what we see in adults. If you or I don't have a good night's sleep, we're very lethargic the next day, what we call daytime somnolence, and we're, wanting to just go home early. With a child who is not sleeping well, almost the opposite happens. You have this hyperactivity disorder. So many of the really disruptive kids you see or you will see in your career, you really should be asking questions like, does this kid snore? Does this kid sleep with the mouth open? Does this kid wet the bed? Does this kid grind their teeth? And if these sorts of things come back, yes, it's really important to co-manage that patient with a respiratory sleep physician, because some of the things that you're seeing dentally are actually caused by their sleep disordered breathing. So obstructive sleep apnea is part of the sleep disordered breathing spectrum. Other things include primary snoring without apnea, upper airway resistance syndrome, mouth breathing in itself. And if you've heard David McIntosh speak, he is closer to you guys. He's an ear, nose, and throat doctor, but he has a big focus on working with dentists because he says that dentists pick up the narrow palate more than any other profession. And that's because we're looking at the palate on a daily basis. Ear, nose, and throat doctors kind of work above the palate, turbinates, septal deviation, large adenoids, etc. We work below the palate, and we're talking about the dentition. We're also talking about the functional occlusion and whether the palate is in crossbite, etc., etc. So my background, I did my dental training in University of Sydney many years, 36 years ago. And then I went to London and did my master's in orthodontics. And I was lucky in my last year of the 3-year program to get to know people in the field of airway, such as Sten Linda Aronson, who was my academic chair when I started doing my research in Karolinska Institute in Stockholm. And what they showed me as a young orthodontist is that the cause of many malocclusions is very much related to poor tongue posture and poor nasal breathing, as opposed to what I thought and what we were taught in dental school, which was genetics. Like mom has big teeth, dad has a small jaw, that's why Johnny has crowding. That's actually not really the case, and there's nothing to support that in the scientific literature. So I'm happy to send anyone what I'm presenting tonight is pretty much a summary of my 15 years research leading to my PhD thesis, where I had a null hypothesis, and that was if a child has sleep disordered breathing problem, does that increase their chance of having a malocclusion? And if so, what type of malocclusion is common in these kids? So I'm only going to do this for an hour. This is obviously like a 2-day lecture, even into short form. So I'm happy to send you all the references and all the slides. All you need to do is just shoot my PA an email, and her email is listed there. So it's just info at derekmahony.com. And I can tell you the future of dentistry is what's called airway-related dentistry. And if you listen to people like Jeffrey Rouse, who's very famous prosthodontist, he talks about failure of implants and full mouth reconstructions falling apart based on sleep bruxism in adults. So a lot of things we see in the mouth can be directly or indirectly related to the sleep. And I don't want to launch into adult sleep medicine. My degrees are my dental degree, obviously, my orthodontic degree. I then did further training in dentofacial orthopedics. And my last degree is in dental sleep medicine. So putting all that together, I'm able to kind of share with you what I see now with my orthodontic hat versus what I see with my sleep medicine hat. And the photo here is Professor Christian Gumino, who is really a mentor to me in understanding all of this and in helping me put together a proper proposal, particularly for the ethics committee, to be able to say to them, I need to have children who have sleep apnea, who have sleep-disordered breathing as a control group to see if we do nothing, what happens. And he passed away a year and a half ago. It was a sad loss to our profession, but he pretty much headed up the research department and the head of sleep medicine at the very prestigious Stanford School of Medicine. So let's start with sleep-disordered breathing. It is very common in children, and the manifestations would include poor attention in class, hyperactivity disorder, bruxism, snoring, chronic mouth breathing, all of the above. Now, here's some interesting facts, and these are actually Australian-based facts. A child who snores is going to be 4 times more likely to be in the bottom 25% of the class. And if you ask a parent, does your child snore? What do you think the response is going to be? 9 times out of 10, the parent's going to say, I don't know, because young Johnny sleeps 2 bedrooms on the other side of the house. So there's a free app, which I recommend to parents. It's called Snore Lab, SNORELAB. And you can put it on any smartphone. It doesn't cost you anything. You put it next to the kid during their sleep, and it picks up labored breathing. It picks up snoring. It's very, very accurate. And it's not a sleep study, but it's a great way to answer the first question. Because if the child snores, that is not normal for a child. And many parents don't get that. I get, mums that say, look, I don't know who's the worst snorer, my husband or my child, and they kind of laugh it off as a contest. And I kind of make them understand that if a child snores, there's a high correlation between that and the sleep disordered breathing problem, which means that their oxygen saturation is dropping to dangerous levels. It also means that their cognitive performance is reduced. If you have undiagnosed sleep apnea as a kid, you can lose up to 10 IQ points per year. This is the research of Dr. David Gozal in University of Chicago. So if you look at the average IQ, it's about 90. So if a kid's got 2, maybe 3 years of undiagnosed sleep apnea, they're never going to recover with that loss of cognitive performance. And this is sad because these kids end up in the bottom part of their class. These kids are sometimes misdiagnosed with ADHD, et cetera, et cetera. So I want you just to understand that when you're treating a child, if you see lots of wear facets, ask the right questions. If you see cracked, ripe lips, if you see at the back of their throat, their tonsils are enlarged, if you see their uvula is really endematous and inflamed, all of these are early signs that that kid may be having these problems going on. And guess who the best people are to pick up these problems early? It's the dentist, because we spend more time looking at someone's mouth than any other profession. You'd think it's the medical doctors who'd pick this up, but in actual fact, many of the physicians are obviously not looking at these early signs and symptoms. And that's where I like to say that you as young dentists or dentists to be are really going to become gatekeepers of these little kids' airways. And if you can pick up a problem early, refer at the appropriate time, do some interceptive treatment. And where will you get involved in treatment modality? In arch development of the upper jaw to improve nasal breathing, in repositioning of the lower jaw to improve the area behind the tongue, known as the oropharynx. And if you increase nasopharyngeal airway and velopharyngeal airway and oropharyngeal airway, that child has less chance of the problems that they're currently experiencing. So it's a multifactorial treatment. It involves ear, nose, and throat doctors many times. It involves sleep physicians, obviously, to make the correct diagnosis. It involves general dentists getting in helping in identifying the problems, and also in early interceptive treatment, which is what my passion is. Look, when I graduated from orthodontic school, I never treated any kid in mixed dentition. Pretty much everything I did was permanent dentition. If kids had crowded teeth, I'd measure the millimeters of crowding, and if they were greater than 5, I'd pull out 4 teeth. I now realize that pulling teeth out gives you the room quickly and allows you to line the teeth quickly, but it sometimes narrows the palate and worsens the tongue's position, right? So, so all of these problems can lead to what we know now as sleep disordered breathing concerns. So I'm more into looking at kids early. 7 to 9 is the ideal age, asking questions about their sleep and their behavior, doing sleep studies, and measure times doing something really simple. If you just measure the distance between the upper first molars, like from the palatal CEJ to palatal CEJ, for a kid who has a good airway and a good arch form and no need for arch development, that distance will be about the same as a cotton roll. Research from Harvard University, Professor Maurice, he showed that kids who develop an arch that doesn't need major orthodontics, on average, have an intermolar distance of 37 millimeters. A cotton roll is about 38. So, if you just add to your examination of these kids a measurement of the intermolar distance, it gives you an indication. Now, please understand that when a kid's 7, the first molars are fully erupted, right? I used to think that 8, 9, 10, 11, 12, that jaw is going to continue to grow, but the width and the palatal vault doesn't really change. It's formed early. That's why kids have large heads when they're born. So the intermolar distance at 7 is pretty much going to be set for the rest of your life. And the thing is that if you can get in between 7 and 9, it's really easy to expand the palate. And if you do it slowly, that high palatal vault drops down and improves the nasal breathing. Plus, it makes room for the teeth, which minimizes the need for major orthodontics later in life. And as I said, the things I'm going to share with you today, and I just need to grab my external hard drive 1 second. I'm going to send you one quintessential paper that I feel that everyone should read, and that is the American Association of Orthodontists white paper on what orthodontists should be looking at in children as far as their airway. And there's another paper for general dentists. Let me just open it up. Sorry. For general dentists from the American Dental Association, based on a symposium, again, linking dental problems to airway. So I'll share both those documents with you. But I'll just going to play one video to get you understanding what I'm going to be discussing here. So this kind of talks about some of the problems associated with mouth breathing in children. And it's from my colleague, Dr. Herman Ramirez. I think a lot of you guys may be from Canada. He's a good friend of mine. He was a pediatric dentist who then became an orthodontist, and he taught in faculty for many years. Now he's in his private practice. His name's Dr. Herman Ramirez. And I think this is a really good video to make you understand. Just tell me.
The normal or physiological way of breathing is through your nose. Breathing through the nose permits to purify the air by the structures inside the nasal cavity. In that way, the air entering into your naso and oropharynx, your throat, is not going to heavily affect the lymphoid tissue in the adenoids and tonsils, which is the last barrier to catch harmful particles in the air before it reaches your lungs. Besides clearing the air from harmful particles, nasal breathing stimulates the production of gases and substances in the nose, which are going to facilitate the entrance of the air in the lungs.
And one of those most powerful substances is called nitric oxide. Nitric oxide is a powerful vasodilator that helps all of these tissues of the pharynx remain patent. And if you breathe through your mouth versus through your nose, number one, the air going through the nose is not filtered by the nasal hair. Number two, it's not humidified by the terminates. And number three, you don't have that release of the nitric oxide. So mouth breathing, that germ-laden air is going straight into the primary defense system of the lymphoid tissue, which is your adenoids and tonsils, which are going to swell and cause further obstruction. And that's where this catch-22 continues. So if you can pick up mouth breathing early and you can help to change a mouth breather to a nasal breather, the tongue is really going to help you develop the jaw. So between 0 and 6, the tongue is the best expander because that's how nature works. From 7 onwards, when that intermolar distance is too narrow, the tongue ain't just going to do the expansion. That's when you're going to need to do some orthopedic expansion.
And prevent infection in your respiratory system. Mouth breathing allows the air to pass directly into your throat, where the adenoids and tonsils are located. In that way, the air entering into your body through your mouth has not previously been purified, and the lymphoid tissue in the adenoids and tonsils become the first defensive barrier against the harmful particles contained in the air. As a consequence, that lymphoid tissue overgrows, occupying a large volume of your throat. That makes more difficult for the nasal breathing.
And it's pretty easy for you guys to see the tonsils just by getting a mouth mirror and pushing the back of the tongue down and getting the kid to say, ah, right? And I'll show you some diagrams of that. Adenoids, you can actually see with a bit of experience by getting that same mouth mirror and putting it under the soft palate and looking up. You can also obviously see it on a lateral cephalometric radiograph, but you can hear it. You know, the kid's very nasal. So rather than say banana, they're going to say banana, you know, and so you can pick these kids a mile away. They have a longer face, they have incompetent lips, they're going to have a history of recurrent otitis media or middle ear infection. And why is that? Well, I'll show you. If you see the 2 purple balls here, that is the adenoid and tonsils, and they are right in between the opening of the eustachian tube. So what's happening in these kids who mouth breathe, they get a double-edged sword because all the germs are creeping up the eustachian tube. There's your cause of infection, not what people used to think, which is external, media such as swimming in dirty water, etc. The other problem is to clear the eustachian tube at a young age involves proper swallowing. So if everyone does this now, if you swallow and you swallow with your tongue on your palate and your teeth just touching, see what happens in your ear. Everyone do that. Put your lips together, tongue on the palate and swallow. Tell me what you feel in your ear. Most of you should have heard a pop. What is that pop? That's your eustachian tube being cleared by 2 muscles, tensor and levator palatini. Now, if you're a mouth breather and you don't have that proper swallowing pattern, you're not clearing your eustachian tube. So number one, your eustachian tube is germ-laden. Number 2, it's not being cleared efficiently. And number 3, as a young kid, your eustachian tube is kind of parallel, so gravity is against you. That's why there's a high correlation between mouth breathers and recurrent otitis media. And the old way of treating them was just to put grommets. The modern way of treating is actually change the breathing and widen the palate.
and you make a habit of breathing through your mouth. In order to breathe through your mouth, your lower jaw has to come down, as well as your tongue has to rest on the floor of your mouth. Breathing through the nose is the correct way, and so the tongue is able to rest on your palate, stimulating a normal growth and development of your upper jaw. Conversely, when you breathe through your mouth, your tongue has to descend and protrude. At the same time, the pressure of your cheeks increases, pushing the upper jaw inwards. So the growth and development of your upper jaw is negatively affected, resulting in a narrow and high palate. The upper dental arch acquires a V shape instead of being a rounded dental arch.
So this is where I come in as an orthodontist, or you as a general dentist doing simple orthodontics, and that is to identify the crossbite and narrow palate and realize the cause of it. Fix the airway, widen the palate, then retrain the tongue to sit up on the palate. And, you will, in your graduating years, work a lot with oral myologists, which are like speech therapists who have done further training in tongue retraining. They can't expand the jaw. That's where you come in. You can't clear the adenoids and tonsils. That's where the ear, nose, and throat doctor comes in. But it's a real team effort. And the parents love you for it because you give them back a different kid. You give them a kid who's at the bottom of the class, not doing well, not sleeping well, to a kid who sleeps perfectly, is attentive in school, and is not that obnoxious kid that no one wants to be with. Because if you have ADHD, let me tell you, if you've had kids yourself, when they're young and they stay up 1 hour past their bedtime, well, what do? They don't get tired. They start climbing the walls, right? So a lot of the disruptive kids that we've been dealing with for years in dentistry, we now link to their sleep pattern. And the early signs you see in the mouth are indicative factors of this problem, sleep disordered breathing.
Therefore, your teeth do not have space to properly align. This also produces an incorrect swallowing function. Every time you swallow, between 1,600 to 2,400 times per day, the tongue positions low, staying away from your palate. That forces the tip of your tongue to position between your upper and lower front teeth. That pushes your front teeth to show out of your mouth, and your tongue resting on the floor of your mouth with the tip of the tongue between your front teeth. That is called an open bite, as your upper and lower front teeth do not touch when you close your mouth. All those dysfunctions, mouth breathing, incorrect tongue posture, open mouth, and incorrect swallowing are going to continue affecting the growth and development of your upper and lower jaws. And as a consequence, there is less room for your teeth and they become crooked. Remember, the nose is for breathing and the mouth is for eating. Breathing through your nose and keeping your mouth closed with your lips together is going to help your upper and lower jaws to grow and develop better. But more importantly, it makes you healthier.
Yeah, so that's just like a little bit of, where we're going with this. And, obviously it's a short lecture, but the point we're making is it is possible for you when you're looking at kids to start measuring the palatal width and start looking for things like venous pooling, under their eyes. And I'll show you that. Asking questions about their sleep and snoring. And, these are all the things that you'll find in your medical history if you ask the right questions. The desaturation is an interesting one, right? So you obviously can't, as a dentist, do your own sleep study because we're not trained in that field. But what you can do is send a parent home with a really simple, inexpensive pulse oximeter. And the pulse oximeter is going to tell you whether or not that kid is having oxygen desats. Now, if they're having oxygen desats, without a doubt, they're one of these kids, right? And that's without spending big dollars on a sleep study. Depending on where you are, if there's no Medicare funding, a private sleep study is about $1,000 for one night. And not every parent can afford that. In our public system, which is overburdened, sometimes you have to wait 1 year to just get the sleep study done. So this is a great way. It's not a sleep study, but I want you to just go away and do 3 things, right? Look at the kid, ask the right questions. What are the right questions? It's a questionnaire called the BEARS questionnaire. Really simple, doesn't cost you anything. parents just fill it out. I'm happy to send you a copy of that. Just email me. Number two, get an oxygen saturation while the kid's sleeping, 1 night, 2 nights, whatever, right? Number three, use that Snore Lab app. So all those three things didn't really cost you anything, but a great way for you to show the parent that your kid has a problem. And then that motivates them to have the proper sleep study done. You know, the more you start looking for these things, the more you find they're apparent in a large percentage of your children. In fact, in my study, which was like, you know, many thousands of children, probably 90% of the kids who had a malocclusion also had sleep disordered breathing. So that's why you've got to realize the modern orthodontist is actually treating airway first and teeth second. Because if you don't fix the airway, if you don't fix the jaw structure, moving your teeth is going to relapse. For those in the audience who've had braces maybe at 13, 14, you know, without retainers, how straight did your teeth stay? And I can guarantee you most of them, the teeth have moved. And why is that, you know? So if you can, let's start building a house. If you put the foundations down and they're stable early, whatever you build has a better chance of success. Same deal with orthodontics, right? So I want you to understand that sleep disordered breathing is a chronic disease and it has multiple risk factors. So you can't just do one treatment. I can't say, all right, go to the nose and throat, you're going to be resolved. No, it might reduce by 50%. I can't say, let's widen your palate, bring your jaw forward and you resolve. No, that might increase it by 40%. I can't say, let's just do oral myology and teach your kid to put the tongue in the right position and sleep with their mouth closed. So no single treatment of obstructive sleep disordered breathing is 100% effective, right? We know that from all the research. We also know that if you do a short-term cure, such as T's and A's, that doesn't prevent long-term recurrence. So I think you've got to understand it's a team approach. We can now accurately phenotype what sort of patient we're looking at. It's going to be that kid who has a narrow palate, has a class 2 jaw relationship, has a longer face, right? And after we've fixed the airway with the ear, nose, and the throat, after we've brought the jaws in the right position, we then need to maintain that position and keep that muscle active by doing what's called orofacial myology, which is a big field now in general dentistry. So let me show you another little video to explain that. Hopefully it's on this same drive. So many of you would have had a skull during your dental school, and if you're lucky, you'd have an exploding skull. What I'm trying to show you here is that development of the palate, if you do it at the right age, has a huge effect on the nasomaxillary complex. So it improves your nasal airway and helps your maxilla to grow forward. Keep an eye on that yellow bone, which is your sphenoid, and look how many bones it's linked to, right? In particular, look at your palatine bone and your maxilla, which is 2 bones. So stimulation of those sutures, which is your cruciate suture, which is at the back of the palate, also known as the palatomaxillary suture, your premaxillary suture, and of course the one everyone should know, which is the mid-palatal suture. Stimulation of those by the action of the tongue when you're young permits what's called intramembranous ossification, which is normal development of the palate. Your tongue being in the wrong spot, like if you're tongue-tied or you suck your thumb or your mouth breather, the buccinator takes over and constricts that. Does that make sense? The second is by expanding that, which is after the age of 7, and doing it slowly. So you get remodeling of the palate. You're also stimulating forward growth of the jaw. You're improving the airway, and you're lessening the chance of that kid needing major orthodontics, including extraction of teeth. Yeah, so just showing you some information, make you understand what we're discussing here. Let's go back to the main sort of lecture. So this is the correct definition of obstructive sleep disordered breathing. It's a syndrome of upper airway dysfunction during sleep. It's characterized by snoring, as I've discussed, by increased respiratory effort. That means, like, if you're drinking water from a straw, I come and grab the straw and constrict it, you got to do more effort to get that water in. Same with you've got nasal obstruction problems, collapse of your nasal valve, large inferior turbinates, etc. Then we have primary snoring. We have upper airway resistance. We have obstructive hyperventilation, which is snoring with abnormally elevated end expiratory carbon dioxide, the partial pressure, the oxygen desats, etc. And then the dangerous one, and the one that everyone bangs on about, is obstructive sleep apnea syndrome. And that's where you get partial or complete upper airway obstruction. So, we need to realize that we're looking at a bigger picture. Now, if you look at the girl on the left, she has a really narrow palate, right? And I can just sort of mark these diagrams. Yeah, great. So, all right, try and do this properly. Yeah, look at her palate. You can see that high palatal vault. You can see the tongue has never really been there. And you can see she's got no room for her cuspids. Her lateral and her canine are right next to each other. The good news is she's a young kid, so that suture's wide open. It's really easy to expand at that age, right? Look at her profile. It's what we call class 2, and it's class 2 not because the upper jaw is too far forward and we need to pop out teeth and pull the incisors back. It's narrow because her tongue is not doing its job, causing the lower jaw to drop back. Now, in that photograph, we've asked that little girl to bring her lower jaw forward. And when she brings her lower jaw forward, you see the true problem. The upper jaw just doesn't match it. But her real bite is like a 10 millimeter overjet. Does that make sense, right? And look at that little kid. You can see her, I'll change the color here to blue. Look at her lower lip trap. I mean, those lower lips getting caught behind the upper incisors. Do you think that girl gets teased at school at age 8? Of course she does. She's going to be called Bucky Beaver. How do you think that little kid feels at Easter? She's probably really busy. But seriously, you don't want to say to that kid, hey, you're too young for orthodontics because you haven't got all your adult teeth. Come back when you're this boy's age. So she's the perfect age, right? What's the perfect age? 7 to 9. That's the time you should be getting in and looking at all these features. Even earlier, obviously, to avoid any orthodontics. If you can pick up tongue tie and mouth breathing, anything that's affecting the tongue hitting the palate really early, the tongue will become jaw expander. But remember, after 7, that intermolar distance is not going to naturally increase. You need to use something like an expander to do that. But look at this guy. This guy is 14. And many people view that as that classic orthodontic age. And that's when I used to treat. And what would I do? I'd take one look at that kid's teeth and I'd say, my God, you got no room here. I'd call mum and dad in. I'd say, listen, Johnny unfortunately has big teeth from you, small jaw from you. The only way I can fix this is by pulling 4 teeth out. But look at his face. He's got a long face. His upper jaw and lower jaw are too far back. I didn't ask questions like, do you snore? Do you think we should get a sleep study? I had no clue. I would just go in for the kill and straighten the teeth, and back when I graduated from orthodontic school, I would say, men were men and premolars were always nervous. I would, in a heartbeat, pull out 4 teeth there and I'd get those teeth straight, but I wouldn't improve the airway and I wouldn't change any facial balance because the horse is already bolted. So what I'm saying to you as young dentists, go and do some more advanced training, and I can give you lots of links and lots of YouTubes and stuff you can do in your own time that actually doesn't cost you anything. I know you guys are in like year 4, maybe. I believe, at least that's what I saw. I know you've probably spent a fortune on your dental education, and maybe some of you are pissing off back to Canada, some are staying here, whatever. You owe it to yourself to further your education in the field of dental sleep medicine. There's great academies like the American Academy of Dental Sleep Medicine. They have lots of online courses. As a young grad, you kind of get gratis invites to lectures to attend. I can give you lots of links to help you with that. But put on your bucket list, you got to get through your program right now. Great, pass your exams. The moment you do, start focusing on airway, because this is going to make you such a good dentist. Your parents are going to love it because no one else in that healthcare profession has picked up these problems. When you pick it up, get the sleep study, get the kid better, they're going to love you forever. They're not going to leave you because you're, not a no-gap dental or not a preferred Bupa provider or whatever. They're going to stay with you because you're a real doctor. You've diagnosed an underlying medical condition from your dental know-how. That's really powerful. So yeah, I can't do much on this 14-year-old other than orthodontic surgery if I want to get a good result. But if I got that kid at 7 to 9, same malocclusion, I could do something positive, right? So here's a girl that has the same profile. So the little girl, 7 to 9, the teenager, and this girl who's 25, all have the same problem. It's what we call a class 4 malocclusion. What does that mean? It means the upper jaw is narrow. It means the upper and lower jaw too far back, and it means the face has got longer, right? You'll learn that when you do some basic cephalometrics. So can you see her face, right? Now, she is not presented because she doesn't like her face. Deep down, she knows she's got a pretty, unattractive profile. But really, she's presented because she has sleep apnea, right? She stops breathing at night. She snores. So what's her treatment? Well, at that age, she's had surgical expansion of her top jaw, and both jaws move forward. It's what we call an MMA. And you probably won't be exposed to it as an undergrad because you're still learning minor oral surgery. This is maxillofacial surgery. And look at the girl's face. Does it look better? Of course it does. Why? Because it's balanced. It's where nature should have had it in the first place. Now with her upper jaw wide and her jaw's forward, her airway is not collapsing. She doesn't need a CPAP anymore. So she's more attractive. She's sleeping better. She's not tired during the day. What an amazing thing you can offer your patients. But it's sad she's had to go through a fairly major surgery to achieve that. Whereas if you'd been awake when that kid was 7 to 9, she could have had really simple interceptive orthopedic treatment to get her back to normal, to minimize the need for her teeth coming through crowded like the guy who's 14. I kind of hope you get that. Here's a girl that is also class 4. And look at her change. From there to there, that kid is 7 in that photo. She's 10 in that photo. She hasn't had 3 years of treatment. She's actually had a year of treatment. What has the treatment been? Widen the palate, appliance to bring the jaw forward, and then teach the girl to keep her mouth closed and breathe through her nose. I mean, look at the difference in that girl. If you show that to a parent and you say, look, which kid would you like? The girl on the left, who would normally be left till age 13 and end up with horrific crowding and a massive class 2, and then you'd have ways of pulling things back. That's not going to help the airway. Getting in early, widening the jaw, bring the lower jaw forward, that's what's going to help the airway. Let me show you one more video, because videos are a great way to get information to you guys really quickly. So this video is going to kind of show you the point of what causes the narrow jaw.
A normal upper arch should look like this. It forms that way because the tongue rests in the area between the upper teeth. There, it counteracts the pressure of the cheeks, which would otherwise push the upper arch of the jaw in. But if a child sucks his thumb or breathes through his or her mouth for any reason, then the tongue drops from the top of the mouth and the upper arch can get pushed in. The narrowed upper arch has a knock-on effect on the lower jaw, forcing it further back and down.
So can you see how the class 2 problem occurs and where the crowding occurs? So when do you want to treat? When the jaw stopped growing and you can't change, or while the jaw's still growing? That's kind of like the take-home message for tonight. And I'll just show you that little device you can use to measure oxygen desats. This research was done at Stanford. There's 2 little devices. The one for the adult kind of like goes on the finger. The one for the child literally goes around on the thumb. And, you know, they can sleep normally. There's no wires and anything like that. And it's just measuring when they drop their oxygen level. So let me just tell you, normal for kid is 99%, right? So let's have a look at this video and see what's going on. So that's the device. Unfortunately, the computer just found under Stanford subdivision the adult one, but it's kind of like the same. Just the kids one goes on the thumb, and I'll show you photos of that and send you information. But this machine is like top of the range machine. It's like $150, right? Why wouldn't you just use this as a guide? Now, this guy has sleep apnea. Genuinely. You'll see he's class 2. You'll see he gets home from work, he's dog-tired, he turns the telly on, within minutes he falls asleep. For adults, you use a questionnaire called Epworth Sleep Scale. For kids, you use a questionnaire called Bears Questionnaire, but they both ask questions like, you know, in front of the telly, what are your chances of dozing off? You know, blah, blah, blah. And you'll see what I mean. So he starts with fairly normal oxygen stats. There's your snoring. So remember, this is not a sleep study, but if you have the Snore Lab app on your phone and this going on, it's really accurate to pick up these problems. Look at his oxygen saturation dropping and his heart rate increasing as he labors to breathe. So what's going to happen now? The body's going to say, the brain's going to say, hey, dude, wake up because you're not getting enough oxygen. And sometimes it's a micro arousal. He doesn't know it's waking up. Here, it's going to be an actual apneic event. So look at the sudden increase in the pulse rate because of that blood oxygen dropping. Now with apnea, this could be happening multiple times per hour. You understand why he never gets to a deep sleep? And you as the dentist could be the first person to have that discussion. So that's what the little chip in that machine prints out. And it's a great way of referring to an ear, nose, and throat doctor saying, hey, my patient definitely has signs and symptoms of sleep disordered breathing based on what I'm showing you here. But as I said, the Stanford protocol is in this paper published by Associate Professor Stanley Liu, who's a bit of a legend. He's a dentist who then did medicine and then did ear, nose, and throat. So he's a head and neck sleep specialist. And it explains step by step what's required when you look at the signs and symptoms. So I'll send you that paper with all these slides. Now, we're kind of running out of time because it's just like, as I said, a 1-hour lecture. But I will leave a couple of minutes for questions. But here's a student of mine. He's a dentist. He's switched on. And he says to me, I just got called a lifesaver today for referring a child to an ear, nose, and throat who was bruxing like a demon, right? He saw at 6 that this kid had like no anatomy on any of his teeth. He referred him to an ear, nose, and throat. Tonsil adenoids were removed. 6 months later, the kid comes back for their dental review. And he already sees that the palate's starting to get bigger. Why? Because the tongue's doing its job. But the mum says, my God, my kid is so much better at school. He thanks me for educating him and David McIntosh for working with him, ear, nose, and throat, right? That was on DPR. It got like over 950 likes and comments. So you're a young dentist. Maybe you haven't been taught this in dental school. I get that. In dental school, they had enough time to teach you how to do a root canal, things like that. But this is the future, and it's really, really important. I have a number of published papers, this one in the Australian Orthodontic Journal, where I discuss what happens if you change the mode of breathing from mouth breathing to nasal on the development of the jaw and the less chance of malocclusion. But it's not new, right? In 1909, the precursor of the Journal of American Dental Association, which now is called JADA, used to be called Dental Cosmos. And in 1909, they already were linking the two professions, the ear, nose, and throat doctors and the dentist. And they were saying the crossover point is really orthodontia, because if you're a mouth breather, early symptoms include narrow palate, crowding, chin receding, which is your class 2, your dental arch is contracted, which is less than 37 millimeters. And this is in 1909. And look at the big one. Teachers will accuse these children of being inattentive at school. This is in a dental journal in 1909. So we might have new bells and whistles that allow us to identify this, but it's been around for a while. And we talk about cognitive performance. Look at this paper before the Pennsylvania Dental Society in 1910 talks about brain development being retarded because the kid's getting not enough oxygen. So it's a really important aspect of care. So doctors, I obviously have a short time to present a lot of info. I will send you this BEARS questionnaire, and I want you to start using it in your pediatric population. It's really easy for the parents to fill out. Get yourself that Snore Lab app, and then you'll be able to start working in conjunction with orthodontists, ear, nose, and throat doctors, sleep physicians to develop the jaws, to maybe protract the jaw forward if you need to, using a thing called a face mask, to bring the lower jaw forward if you need to, using a thing called a Mara, and then retain it with myofunctional therapy, right? So there's about 1,000 slides in my lecture. I'm happy to send all of you guys that info. But this is what I do now. I sit down with a parent and I say, hey, young Johnny came to me class 2 at age 8, which is this diagram. Oops. This diagram you see here, right? But forget about his class 2, forget about dental stuff. Look at his airway. This is using CBCT. And you can see he's in the red, right? Whereas after he's had his jaw developed in the maxilla and his lower jaw brought forward, he's in the white. So, you know, the parent doesn't need to be shown this stuff. They're telling you already, Dr. Mahony, you've given me a different kid. He is paying attention at school. He sleeps well, you know. But, you know, the grandparents are saying, what has happened to young Johnny? He looks so much more attractive. Of course he does, because his jaws are now balanced. A good face is a good airway. There's no doubt about that. Or you can wait and do nothing and have this kid who has this really narrow airway behind the tongue and has a very narrow palate. And then what you do is a maxillary advancement and a mandibular advancement. That's like major surgery. But guess what? Look at the airway, and I'll do that just in red to show you. Sorry. Look at the airway there and look at the airway there. Can you see the difference? Look at the face, right? But the thing is, you can do those facial changes without surgery if you get the kid at a right age. Okay, do you guys have questions for me before we wrap up for tonight?
Hi everyone, can I just get you all to either unmute yourself to ask questions or feel free to comment in the post that I've posted in the event page. Unfortunately, our chat function is disabled for this particular lecture and I can't get it to start up again. So if you don't mind posting your comments in the actual event page and I'll read them out to Dr. Mahony, or feel free to unmute yourself and ask your questions. Thank you.
Oh. Where? All good, no takers?
So we've got, we've just got an anonymous question. What is a class 4 malocclusion?
Okay, a class 4 malocclusion is when you do your cephalometrics, the maxilla is back and the mandible is further back and it's a long face. So it's a very specific, so class 3, many people think is a big jaw. Actually, I think I've got a slide here. But many class 3s actually have a normal mandible, but their maxilla is back, right? So imagine you have that retrognathic maxilla, and on top of that, you have a retrognathic mandible. That is a class 4. I'll just show you the paper. So it's a retrognathic maxilla and a retrognathic mandible. So in class 3s, we know most of the patients have a maxilla that's back. In class 2s, we know that most of the patients have a mandible that's back. A class 4 is both of those jaws being back and a long face. And the reason I'm saying that, that is a 100% indicative of sleep apnea. So if you do a ceph tracing on a kid older than 7, why? Because after 7, the cranial base has stopped growing. So you can then pick where the maxilla and mandible are going to be. And if you see both their jaws are back and long, that is 100% going to be a need to get involved in a sleep study. So, you know, that's now termed in the dental sleep medicine world a class 4 malocclusion, right? Years ago, class 4 in my practice was a patient I didn't want to treat. So I would tell my nurse taking the records, this was a class 4 malocclusion. And straight away, she knew that the mum was a pain in the ass or the kid was disruptive and we just didn't want to deal with them. But a true class 4 is actually what I've just described. So the best airway is going to be in kids that have a class 1 occlusion. Maxillary mandible is where it needs to be. Or some patients have biskeletal protrusion, even better airway. Do you understand? What are the kids who have the airway problems? The class 2Bs, where the mandible's back, the class 3As, where the maxilla's back. So what we call a class 4 is that both jaws being back. I hope that answered that question in a really short way. Maybe you guys don't really even do cephalometrics. I'm not 100% sure.
We actually did start doing cephalometrics, but quite briefly, and it's introduced only into the 3rd year program. But I think in general, we don't have enough on orthodontics, so we're always a little bit desperate to know a bit more about ortho and this particular stuff. I've just got a question for myself. So with regards to interventions, is it earlier, do you find it's more successful to have treatment the earlier you detect the sleep apnea? Like, is there a particular age in children that you recommend doing these assessments on, or is there, a study that shows?
So if the kid 100% is diagnosed with sleep apnea, you got to do it as early as possible. But the best time for growth is going to be during what's called, like if you look at the vertebrae of the cervical spine, you can time when you're going to get maximum maxillary growth, right? Now, say you look at this little girl, just as an example, just make it clinical. So this girl, for most orthodontists, they wouldn't touch because, she hasn't even got her permanent incisors. But her history of chronic mouth breathing and snoring put her in a sleep study, and the sleep study showed her to have severe sleep apnea. Now, in the old days, when I got into sleep medicine, this girl we put on a CPAP. And the CPAP does what? The pressure of the CPAP prevents the upper jaw from growing forward. Now, if you look at her face, you see her upper jaw is already recessed, right? She's class 3 because her upper jaw has not grown. So because of the sleep apnea, you don't need to be a rocket scientist or have an orthodontic degree to realize there's no way in hell her teeth are going to fit into that jaw, right? But the main thing is, if you look at her airway, her upper airway, what I'm showing you here is called the, why is that not working here? What I'm showing you there is an area known as the velopharynx. Now, she's just had expansion of her jaw and used a little device at night to bring it forward. Look at the difference in that kid facially. Remember what I was saying? A good-looking face is a good airway. But she's had early treatment not because she wants to look more attractive, but because she had sleep apnea. That early orthodontic treatment has cured her sleep apnea. Whereas if she was on a CPAP, she'd be on that CPAP for many years because it's not really fixing the problem. Do you understand what I'm saying? So maximum growth of the maxilla occurs between 7 and 9. So that's when I want to get in if I'm going to fix these. But if it's really bad sleep apnea, we even get in earlier. Does that answer your question?
Yes, it does. Thanks, Dr. Mahony. We have one more question.
Yep.
So this is from Monica Glavin. So she's mentioned that she's heard talks from orthodontists about how the extraction of teeth for ortho treatment negatively impacts airway space, possibly causing obstruction. Could you please explain this?
Okay. It depends on the original malocclusion, right? So if you have an original malocclusion where the palate's narrow and like class 4, taking teeth out is going to be a nail in the coffin. But if you have a kid who has broad jaws and is biskeletal protrusive, like a lot of Chinese kids are, if you take out teeth to bring their teeth back, you're not going to really impact on the airway. Do you understand? So it's horses for courses. You can't make blanket statements like if you take teeth out, you're going to cause sleep apnea. If the patient was predisposed skeletally because their jaws are narrow or too far back to sleep apnea, then taking teeth out will do that because what's it going to do? Push the tongue further back. But if you've got broad jaws and just collapsible tissue, then you can't say extraction will cause sleep apnea. And there's been studies to show that in the Chinese population, if you extract teeth because, they don't want to look as, kind of protrusive as they are, and you bring them back to Caucasian norms, that doesn't increase their chance of sleep apnea. So I don't think it's as easy as taking teeth out will cause increased chance of sleep apnea. Taking teeth out in a face that doesn't need teeth out because it's already retrognathic, then that's where the problem's going to be.
Excellent. Thank you so much. We've got one more question from Richard Lee. Can you please discuss the difference between a CPAP and a mandibular advancement splint in terms of treatment for sleep disordered breathing?
Okay, so CPAP pumps air from the nose all the way down to the lung, and it doesn't care where the obstruction is. It just is like napalm way of dealing with problems. And it's 100% guaranteed to work if the patient wears it. Does that make sense? A mandibular repositioning appliance only works on this part of the airway. So if I give someone a mandibular repositioning appliance and I haven't fixed their ear, nose, and throat issues, or their maxilla so far back, or their soft palate collapses, it's not really going to be effective. So where is mandibular repositioning appliances effective? In patients where the airway obstruction is at the base of the oropharynx, right? But that's why you need CBCT and an ear, nose, and throat evaluation to see where the problem really is, right? And can I just say one more thing? Just real quickly, tongue tie is one of the major causes of airway problems because the tongue then flops over the back of the throat. So I have patients who've had a mandibular repositioning appliance, but no one's picked the tongue tie. Does that make sense? So a quick test for you, and you probably, maybe you've not done this, but if you get a patient to lift their tongue, they should be able to lift the tip of their tongue quite easily on the palatine rugae. If they can't, and you see this like V-shaped part of the tongue, or you measure that distance, which is from the insertion of the frenum to where the tip of the tongue is. If that distance is less than 16 millimeters, that's a Kotlow measurement that increases chance of tongue tie. Or the latest research by Audrey Yoon, also from Stanford University. She's a pediatric dentist who did orthodontics and then did sleep medicine. She's amazing. So that's the Kotlow measurement I just mentioned, right? You need to be greater than 16 to be normal. Anything less than 16 is a problem. But she's gone even better. You get the kid to open and put their tongue up on the palatine rugae. Now, when they open and put their tongue there, if they release the tongue position in opening less than 50%, they are tongue-tied. And that means that their tongue is not stimulating the palate. So don't just think it's airway and ear, nose, and throat. It can also be what's called an enlarged lingual frenum. So this dude and this dude are fine. This one and this one absolutely need treatment for the tongue-tied release. And that's a whole different lecture in itself. Maybe when we have more time and you're interested in learning how to do a lingual frenectomy, I can show you. But I do that to release the tongue from the base of the palate so it opens up the airway. Okay. Now, I got to call it a night only because I've worked all day and I haven't had any dinner and I'm starving. So thanks for the invitation. If you guys need any further questions answered, just give me an email. It's kind of like info@derekmahony.com. I am more than happy to respond to you. And if you want a copy of all the slides and all those videos I showed, just send me your email saying, hey, I'm from Griffith University. I listened to your lecture on blah, blah, blah. And I can get my PA to Dropbox all of that to you. All good?
Excellent. Thank you so much, Dr. Mahony. I'll contact Michelle, your PA, and see if we can get a copy of the lecture slides from today. We really appreciate your time, considering you're also an hour ahead in Sydney as well. So we hope to see you again in the future. And thank you once again for your time.
Thank you very much. And I don't know how to pronounce your name. It's like, how do you say that?
You say it Thushika.
Thushika.
Yeah, that's
and your
good.
last name? And your last name?
Udaya Kumar.
Right. And what do your friends call you?
Thush is the easiest way to pronounce it.
Tush. Okay.
Yeah.
All right. Well, thanks for organising this, Tush. We'll be in touch. Bye.
No problem, Dr. Mahony. That's a little intro on how to pronounce Sri Lankan names. Thanks to everyone from GUDSA for joining in tonight. We really appreciate it. And we hope to see you at the next GUDSA lecture series. Have a good night, everyone.